Hello everyone, today we're going to be talking about schizophrenia. Schizophrenia afflicts about 1% of the world population. The word is Greek for split mind, which refers to the separation of the person's intellect from their emotions, which you can see in some people. Schizophrenia is not multiple personality disorder. Some people um, feel or think that it means that a person has multiple personalities, or what we call dissociative identity disorder. That is not what schizophrenia is. And again, you'll learn a lot more about these different disorders if you take an abnormal psychology class. Schizophrenia really leads to a deteriorating ability to function in daily lives based on the symptoms that we're going to talk about. So, schizophrenia leads to an unusual array of symptoms, and we classify them in two main categories. We classify positive symptoms and negative symptoms. Now, when you think about that distinction, positive symptoms doesn't mean good symptoms like positive in a good way. What they mean are by positive symptoms are abnormal behaviors that are gained, that are added to a person's personality or behavior that shouldn't be there. So when I think of positive symptoms in schizophrenia, think of it like a plus sign, like an addition sign, that these are things that are added to the person's personality or their behaviors that should not be there. And these are abnormal behaviors like hallucinations and delusions that should not be part of typical um, emotions and behaviors and cognitions. So they're behaviors that should be absent but instead are there. Delusions are characteristic of schizophrenia, and delusions are what we call unfounded beliefs. These are beliefs that are not true. However, the person has them. They are firmly held beliefs that are simply not true or supported by evidence. So the person may believe that there are aliens living in their house. They may believe that there are people out to get them. They may believe that um, the TV is talking to them and sending them messages. These are just firmly held beliefs that are not true. Um, I when I worked with patients in a psychiatric hospital, I had one patient who wouldn't open his mouth. Um, and took a long time to try to understand why he wouldn't open his mouth, but he believed he had aliens living in his mouth, and that if he opened his mouth, they would jump out and it would be a big problem for the world, so he had to keep his mouth closed. So this was an unfounded belief. No matter how much we could talk to him about it, he still believed it and wouldn't open his mouth. And as you might imagine, if you don't open your mouth, not only can't you talk, but you can't eat or drink, and this can lead to lots of problems. So these are these very strong delusions. Hallucinations, and I'm not sure why I only have auditory hallucinations here, because you can have a hallucination of any of your senses. So auditory hallucinations are the most common. That would be hearing voices that aren't there. So hallucinations are false perceptions, whereas delusions are false beliefs, hallucinations are false perceptions. So auditory hallucinations, someone who is hearing voices that aren't there, and these voices can be like murmuring whispers that they can't even really distinguish what's being said, to actual conversations, to even something that we call command hallucinations. These are voices telling the person to do something. Those can be the most dangerous if someone is having a command hallucination to hurt themselves or hurt someone else. You can also have visual hallucinations, seeing things that aren't there. Um, patient can also have um, olfactory hallucinations, smelling things that aren't there, tasting things that aren't there, and even feelings of things that aren't there. So somatosensory hallucinations. I again remember working with a patient in a hospital, actually at the VA hospital, and I was doing neuropsychological testing his memory and things like that. And all of a sudden he started screaming. The patient was diagnosed with schizophrenia. He started screaming because he was feeling like someone was trying to cut his leg off. We were in a room, there was nobody there, it was just me and him. Nobody was trying to cut his leg off, but he was screaming in pain as though that's what he was feeling. All right, other positive symptoms. Thought disorder. This is difficulty using abstract concepts, a hard time keeping keeping their thoughts in order. They'll jump from topic to topic. Their mind is kind of racing from one topic to another, and so it's really hard to understand um, what they're, how do people express their thoughts? It's with speech, and so their speech is kind of jumping around, and it's very hard to follow. And sometimes as they're speaking, they'll start speaking just in words that rhyme, and all sorts of unusual ways of thinking, and so it's very hard to follow their trains of thought. We see inappropriate emotional displays, so they may start laughing for no reason, crying for no reason. And bizarre behaviors. So doing things that don't seem to be connected to reality or typical ways we would act, walking into the shower with their clothes on. Some people with schizophrenia will freeze, their body will freeze in different positions and they just really won't move. So very, very different kinds of behaviors. The most significant problems, you might say, would be the disorganized thoughts, because the thoughts are really what kind of connect us to reality and to being able to communicate with one another. And so if your person's thoughts are very disorganized and really leaves them unable to communicate, then these are patients, again, schizophrenia ranges on a spectrum from very mild to quite severe. But if someone has a severe thought disorder, then this is someone who wouldn't be able to take care of themselves or to live on their own because their thoughts are so confused. Negative symptoms, so this is the other category, and negative symptoms we would want to think of as like a negative sign or a subtraction sign in math. These are behaviors that should be present, but they're not there. They're taken away from the person. So negative symptoms are the results of a loss of normal function, and this can be reduced emotional expression. Oftentimes people are very emotionless when they are diagnosed with schizophrenia. Cognitive impairments, so difficulties with memory, attention, perception, lack of social interactions. These patients oftentimes just sit alone, kind of by themselves in a corner. And you might imagine if you're having delusions, believing things that aren't true, maybe believing people are out to get you, having hallucinations, hearing voices, they can be scary, thoughts are very confused, then these people sort of huddle kind of to themselves. And so they lack social interactions. We talked about emotional expression. They may stop speaking or speak very little. It's these negative symptoms that are usually stable over time and difficult to treat. Our medications that we have are better at treating the positive symptoms of schizophrenia, and we'll talk about that soon. Schizophrenia has a heritable component. So you can see we've got about 1% of the general population is diagnosed with schizophrenia with no relationship to someone with the diagnosis as well. Identical twins, here we are, monozygotic or identical twins who share 100% of their genes. They have about a 50% concordance rate. Concordance means if one twin is diagnosed with schizophrenia, then the other twin will. So if one identical twin has schizophrenia, there's about a 50% chance that the other one will. Well, that's much higher than the 1% in the general population. And so that shows, again, the more genes in common you have with someone, the higher your risk is. And fraternal twins, those are dizygotic twins, they share half their genes, so they share 50% of their genes. Here's dizygotic twins. Siblings also share 50% of their genes with their other siblings, and their risk is about 17%. So again, so if one fraternal twin has a diagnosis of schizophrenia, the other twin has about a 17% risk. Same with siblings. And so again, they share 50% of their genes, and their risk is higher for developing schizophrenia than the general population, but lower than someone who shares 100% of their genes. So this is evidence to show that there's a genetic contribution to the development of schizophrenia. But some identical twins remain unaffected, so genes alone can't determine who will develop schizophrenia. And you can see that because if it was 100% a genetic disorder, well, if you share 100% of your genes with your identical twin, if one twin develops schizophrenia, 100% of the time, the other twin would. But it's a 50% concordance rate for identical twins. So genes can't be the only influence. Data is consistent with a prenatal influence that perhaps it's many genes that interact with the prenatal and infant environment. So in cases where only one twin develops schizophrenia, that twin tends to have had either lower birth weight or more physiological distress, or something that might we would think of as a kind of pre or perinatal stressor. The affected twin may also have subtle neurological signs, such as impaired motor coordination, suggesting there's some underlying neurological damage or weakness that, again, may be a stressor and then may interact with genes that put the person at risk for schizophrenia. And we do see with adoption studies, adopted children with biological relatives who have schizophrenia have an increased risk. So we do see that there's a biological component as well as an environmental component. In terms of the biology, people with schizophrenia display difficulty with smooth eye movements and impaired motor coordination. We measure this. This was actually the first research I did as an undergraduate student volunteering in a research lab looking at eye movements, or we call them saccades, in patients with schizophrenia. And you have patients with these, when I did it, there were glasses that they wore that have a little camera that tracks the person's eye movements, and they're looking at a computer screen with a dot or something moving from side to side, or all in a different pattern. And typically, people follow the dot in a very smooth pattern with their eyes, and you see in patients with schizophrenia this very non-smooth pattern that they're going back and forth. And so there's all sorts of tests that they do looking at eye movements, and we see more disorganized, less coordinated eye movements in patients with schizophrenia. The genes that influence schizophrenia are probably scattered across many chromosomes. It's not one specific gene that we have found. And some of these genes are known to participate in synaptic plasticity. This DISC1 is interrupted in schizophrenia, but we haven't found a specific gene that we can say this is the gene that causes schizophrenia. Another risk factor is paternal age. So dad's age is a factor that's involved. Older men are more likely than younger men to have children with schizophrenia. And it may be that the sperm of older men are the product of more cell divisions, and every time a cell divides, there's the possibility of a mutation, and so there may be more accumulated mutations that cause errors in copying, and that may lead to a higher risk in schizophrenia. So we end up with this integrative neurodevelopmental hypothesis of schizophrenia that this model emphasizes the interactions of genes and stress, that it's not only genetic and it's not only stress, but it's a combination. That people are perhaps born with genes that put them at risk for developing schizophrenia, But then you need some kind of stressor to happen in their life to kind of turn those genes on and lead to the person developing full-blown schizophrenia. And these stressors can include a number of things. It can be prenatal stressors, like we talked about, or low birth weight, or problems during birth in some way, maternal illness, mom gets sick and somehow that affects the child, puts stress on the developing infant. It can be external kind of environmental stressors, someone who has a really difficult transition from childhood to adulthood. Again, having those genes that put them at risk and then having a very stressful time in this transition from childhood to adulthood. City living has been postulated as a potential issue. The pollutants, exposure to other diseases, crowded conditions, tense social interactions, really anything could be the stressor. And so the idea here is that someone has either fewer or more genes that put them at risk for schizophrenia, and then they have environmental stress from low to more. And so if you have very few genes, there are no genes that put you at risk for schizophrenia, and you have low environmental stress, you don't end up with developing schizophrenia. But the more genes you have, if you have a high number of genes that put you at risk for schizophrenia, and high stress, whether that be prenatal, postnatal, environmental, then that puts someone at greater risk for developing schizophrenia. And again, if you take an abnormal psych class, which I highly recommend you do because it's very interesting, you have other kind of more mild types of psychotic disorders that are more mild versions of perhaps schizophrenia that you might see in people who are maybe somewhere in the middle here. Supporting evidence for the neurodevelopmental hypothesis includes several kinds of prenatal or neonatal difficulties are linked to later schizophrenia. People with schizophrenia often have minor brain abnormalities that originate early in life, and abnormalities of early development could impair behavior in adulthood. In terms of the brain abnormalities in schizophrenia, there are a number of them. But probably the biggest one that we see and talk about most often, and is the one that you can see most easily on an MRI scan for those of us not trained in reading very detailed MRIs, are these enlarged lateral cerebral ventricles. And you can see here two members of each set of identical twins. And here's your person, the twin not diagnosed with schizophrenia and the one who is. And the ventricles are these holes here in the brain. Again, they're important. They must be there. The cerebral spinal fluid goes through those holes as it is going through our brain and spinal cord. But you can see that they're much larger in the twin that has the diagnosis of schizophrenia. And same here. Here's the normal, non-diagnosed twin, and here is the twin with the diagnosis, and those ventricles are much larger. And the problem with much larger ventricles, right, these are larger holes in the brain, which actually means you can see the person has less brain matter, right, compared to the brain matter here. This white matter is practically gone here in this person's brain, and so less brain matter is not a good sign. So the larger ventricles is a very consistent and significant sign in terms of the brains of people diagnosed with schizophrenia. We also see smaller prefrontal cortex, smaller hippocampus, cortical thinning. Cortex, remembers the outer covering of the brain, that gets thinner, and abnormalities in structure and function of the corpus callosum. Sorry, I left that M off there. And here's the idea, and this is in adolescence. So the most common age for someone to develop schizophrenia is typically late teens, early 20s for males, and early 20s, early to mid 20s for females. And so here but you can have an adolescent, you can have a teenager who has developed schizophrenia, a younger teenager, even a child, but it's much less common. And so here is neuronal loss. That's a normal part of development. As you can see here, here's average loss. But you can see in an adolescence with the diagnosis of schizophrenia, you see much more loss of neurons in the cortex over a pretty wide area. The hypofrontality hypothesis. So hypo means less, right? We've all heard of hyper meaning more, like hyperactive, more active. Hypo is less. So hypofrontality, less frontal activity, basically. This is one hypothesis about the kind of cause of schizophrenia, in that we see these functional PET scans that show reduced metabolic activity in the frontal lobes. That leads to this hypofrontality hypothesis that the frontal lobes are underactive in people with schizophrenia. So in these PET scans, you can see the blue-gray colors reflect less activation, and in twins with schizophrenia, the frontal cortex, which is over here, is less active in patients with schizophrenia than their unaffected twins at rest, as well. This was at rest, and this is during a test that actually tests your frontal lobes. It's called the Wisconsin card sorting test. It's a test that really activates your frontal lobe. It makes you be flexible and problem solve. Those are all activities of the frontal lobe, and you can again see that the twins with schizophrenia have less activity in the frontal lobes. So the frontal lobes are underactive. Another hypothesis regarding schizophrenia is called the dopamine hypothesis, and that proposes that the schizophrenia is caused by either excess dopamine or more dopamine receptors, basically more dopamine activity in the brain. Excess dopamine activity can cause behavioral changes that are associated with schizophrenia. And we know this because our drugs for schizophrenia, so they're called antipsychotic medications or antipsychotic drugs, block dopamine. And when you block dopamine, you get relief of the symptoms, particularly those positive symptoms we talked about, like the hallucinations and delusions. So it seems like dopamine is important in this syndrome. The drugs are best if used early, but some patients fully recover, but about 25% don't benefit from medication at all. The other thing in terms of support of the dopamine hypothesis is that cocaine and amphetamines, both of which increase activity at dopamine synapses, induce psychotic behaviors. You can see hallucinations in these people who are using cocaine and amphetamine. You can see delusions. And in fact, when people are coming into the emergency room for with hallucinations and delusions and thought disorders, very often physicians can't distinguish if it's schizophrenia or drug-induced psychosis, which we would call that, like by using cocaine. And so they have to either, do some kind of test for drugs and wait it out and see, is this really schizophrenia, or is this the effect of the drugs that are also increasing dopamine? So those two, drug use in terms of cocaine and amphetamine and schizophrenia, look very much alike. Problems with the dopamine hypothesis is that the medications that we have block dopamine receptors right away as soon as the person takes the medication, so we are decreasing the effect of dopamine, but it doesn't explain that behavior changes weeks later. So you don't get instant change in behavior, even though you're blocking those dopamine receptors right away. So again, there must be something more going on. It can't be as simple as it's just too much dopamine that's causing schizophrenia. Drugs that block D2 receptors much faster than symptoms are reduced, and some effective atypical neuroleptics. Neuroleptics is also like an antipsychotic. These are medications for patients with schizophrenia. some of these newer drugs actually increase dopamine levels in the frontal cortex. And so that kind of doesn't make a lot of sense, even though these medications work, but we see that they're increasing levels of dopamine. So it's not purely dopamine, which leads us to this glutamate hypothesis, that observations of the effects of PCP and ketamine prompted researchers to produce a glutamate hypothesis of schizophrenia, that schizophrenia is caused by underactivation of glutamate receptors, not enough glutamate. So PCP is an NMDA receptor antagonist, meaning it blocks that receptor, and it produces schizophrenia-like syndrome, prevents glutamate from acting normally. We see deficient glutamate activity in glutamate synapses, especially in the prefrontal cortex, and that has the same effect as increasing dopamine. You get those same symptoms that look like schizophrenia, right? The hallucinations, delusions, thought disorders, etc. And dopamine itself inhibits glutamate. So those two kind of go together, and glutamate stimulates neurons that inhibit dopamine. They have this kind of opposite effect. So it could be both, that it's too much dopamine and not enough glutamate that result in schizophrenia. So how do we treat schizophrenia? Well, at first there wasn't a treatment at all. And if someone was to develop relatively severe schizophrenia, there was really nothing that could be done. You could imagine if somebody is having hallucinations and delusions and thought disorders, they were basically put in a psychiatric institution for the rest of their lives because they couldn't take care of themselves, and very often their families couldn't take care of them. And it was kind of, that was it. So people have been looking for a treatment for schizophrenia. In the 1930s, they turned to the idea of a lobotomy, and a lobotomy is a surgical separation of the frontal lobes from the rest of the brain. It can be done, and as we learned with Phineas Gage, you can kind of damage the frontal lobes, which is basically what they did in a lobotomy. And the person still lives, and so the thought was, well, we can do this, and they sort of calm down a little bit. But it really made them dependent on institutional care. As the more they did these lobotomies, the more they realized it isn't so non-harmful to surgically remove your frontal lobes. It actually leaves the people with long-term symptoms that left them pretty much unable to care for themselves. So that wasn't a great treatment. And so in the 1950s, we got our first antipsychotic medication, chlorpromazine, and this worked amazingly to reduce the positive symptoms of schizophrenia. The hallucinations went away, delusions went away, thought disorder went away, and it quickly replaced lobotomy as a treatment for schizophrenia. And this really was the first time that there was hope for these patients, that they could get better. They could go back to, if not living by themselves, at least living with their families or in a group home, but back into society. And these first generation antipsychotics, called typical antipsychotics, and there are now a number of them, not just chlorpromazine, they block dopamine receptors. So again, these D2 receptors. So we think that there's too much dopamine in the brain in people diagnosed with schizophrenia. And so if these medications block the dopamine receptors, even if there is too much dopamine, it's not being utilized, it's not activating the receptors because they're blocked by these drugs. We see effects on the mesolimbic cortical system, Those are neurons that project from the midbrain tegmentum to the limbic system. And again, these drugs, for most people, not for everybody, work really well. But the drugs also block dopamine synapses in other locations. So we're interested in blocking dopamine in the emotional, kind of cortical thinking and emotion areas of the brain. but they block dopamine everywhere, including the basal ganglia, and dopamine in the basal ganglia is really important for movement. And so these antipsychotic drugs can have side effects. One of the side effects is called dyskinesia, and these are initial problematic motor or movement problems, and they disappear when the dose is reduced. However, there is a really serious side effect called tardive dyskinesia. This is a late onset side effect after someone's been taking the medication for a long time, where they have tremors and involuntary movements that just can't be stopped. The problem with tardive dyskinesia is once someone develops it, it's persistent, or meaning it's irreversible. And these tremors can be so large and um, so large that the person can't really function because they're having these consistent tremors. And this is something that once it starts, even if the person goes off the medication, they oftentimes can't get rid of. Might be due to dopamine receptor supersensitivity. So because these dopamine receptors have been blocked for so long, the person actually creates more and more dopamine receptors. And so, the body is trying to get back to this idea of homeostasis. And so now they have so many dopamine receptors that any little bit of dopamine causes a huge response. You can also see supersensitivity psychosis. This is a marked increase in the positive symptoms. Remember, the positives are the um, hallucinations, delusions. So those increase in positive symptoms of schizophrenia upon discontinuation of antipsychotic drugs. So there are some significant side effects that we have to consider, and that, it's this trade-off of really being able to help a person, but constantly watching for those side effects. So there were newer medications called second-generation antipsychotics or atypical antipsychotics. They have a lower affinity for these D2 dopamine receptors, and they actually work on a different transmitter receptor. Clozapine is one of these, and they block that one actually blocks serotonin receptors. These second-generation antipsychotics work very well as well. And again, since they may work for some and not for others, so we try different medications for different patients. They do not have the problem of potentially leading to this tardive dyskinesia. But there's another side effect that's pretty scary. With this one, this is called agranulocytosis. And so this has the potential to lead to a decrease in white blood cells, a significant decrease in white blood cells. And white blood cells are what fights infection. And so if someone is undergoing or having agranulocytosis, that can lead to infections as well as death because they can't fight any infections off. So when someone's taking these medications, they need to have blood tests frequently to be monitoring their levels of white blood cells. So we have some treatments, but each treatment kind of comes, it's a positive and a negative, or a pro and a con, and the doctors are constantly balancing all of this as they're treating a patient with schizophrenia. All right, thank you very much.